Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out reallifepharmacology.com. We've got a free 31-page PDF on the top 200 drugs. Great study guide, great refresher if it's been a while for you, or if you're taking board exams coming up or anything along those lines. Definitely a great resource to have, and simply an email to our email list will get you access to that. We also get you updates when we got new podcasts available as well as other content. So definitely don't hesitate to go get that PDF at reallifepharmacology.com. All right, the drug of the day today is Timolol. This is a beta blocker, and it has kind of a couple of purposes. In clinical practice, it's been quite some time since I've seen it used in the oral dosage form, but I certainly will talk about that a great deal. But I also wanted to mention there is an eye drop formulation, or maybe a couple formulations as well. So as you could imagine, uses for this medication. So if it's a beta blocker taking orally for systemic circulation, we're going to be using that potentially for the usual uses that we use beta blockers for. Atrial fibrillation, hypertension, potentially migraine headache prevention as well. Again, not used very often. There's generally other agents that are preferred, but in rare cases, maybe you will see this. So beta blockers, just a quick reminder, they block beta receptors, adrenergic beta receptors, and ultimately this can lead to a reduction in blood pressure and sympathetic outflow. And that can ultimately lead to helping to treat, obviously, hypertension, but also reducing pulse. And you may see that used in atrial fibrillation as well. But if we, get the pulse too low, obviously that's problematic as well there. So what's unique, special, I guess, about Timolol a little bit, maybe why you really don't see it used a ton, it is a non-selective beta blocker, so it blocks beta-1 and beta-2 receptors. So recall beta-1 is typically found on the heart. A drug like metoprolol tends to be mostly selective for just beta-1 receptors. When we bring in the beta-2 blocking action, that's where we potentially get more issues with blocking some of the respiratory pathways. Remember, beta-2 agonists, like albuterol, for example, those are used to stimulate. So the opposite, an antagonist, is going to potentially worsen that respiratory status. Now, again, all this is dose dependent. The higher the dose, the more blockade you're going to get on those receptors. So, and I'll get into that a little bit more as I talk about adverse drug reactions and the adverse drug profile. Dosage forms, 5, 10, 20 milligrams. Another downside to Timolol, again, another reason why you might not see this used very often, is it generally has to be dosed a few times a day, 2 to 3 times a day, typically. It is recommended to be given with food as well. Now, let's talk a little bit about mechanistically what beta blockers do, or what Timolol ophthalmic administration does. So it reduces intraocular pressure by potentially reducing aqueous humor production. So that's how it works in glaucoma, which obviously kind of reduces those pressures, which is an issue in that disease state in the eye. Adverse effect profile with the topical or the ophthalmic Timolol. I think I forgot to mention, but brand name of that medication is Timoptic. That's the eye drop formulation. Brand name of the oral is Locadrin or Timol. So again, adverse effects for the eye drops, typically just going to be local, maybe some local irritation, redness, itching, that type of thing. But when we get to that systemic circulation, that's where some of the other adverse effects that I alluded to are going to come into play. So some of those systemic effects, so if we're using it, let's say we're using Timolol for migraine prophylaxis, that medication can obviously drop the pulse, and we're going to want to monitor that pulse and make sure it doesn't get too low. If we're using it, again, I can't imagine a situation where you'd want to use it for atrial fibrillation, but if you were using it for that purpose, obviously we're going to expect that, we're kind of slowing that heart rate down, and that's the purpose for using it there. But again, timolol definitely not a preferred agent in atrial fibrillation. Other potential adverse effects you see from beta blockers, fatigue. I've heard patients complain of cold extremities before, where maybe that, adequate blood flow just, gets slowed down a little bit from the beta blocker action. Obviously can drop blood pressure, which, may be what we're trying to do in some situations. That asthma COPD exacerbation risk, I alluded to that with the beta-2 blocking type action. Maybe some GI upset, usually less than 10%, I think was reported in the package insert, but something to pay attention to. And then in patients with diabetes, it can mask hypoglycemia. So I think that's an important assessment to make if you've got a patient that's reporting frequent issues, or we see, maybe they've been to the hospital for hypoglycemia numerous times. That's a situation where maybe a beta blocker isn't the greatest option. Maybe we could look to do something else there. There is a warning with the use of timolol, so it's recommended to avoid abrupt discontinuation. Again, this is going to be more so for the oral formulation where systemic concentrations get adequately high. And the reason for that is you can kind of have this rebound cardiovascular issue where we can get that rebound hypertension, and that can increase the risk for things like heart attack and chest pain and angina and things like that. So definitely pay attention to patients who are non-adherent to medication therapy, or they are sporadic in their use, where maybe they're taking it for some period of time and then they just feel like they need to stop, or they forget for a while, or whatever the case may be. If you've got those type of patients, you really got to be careful with timolol and with beta blockers in general, because we really don't want them to abruptly discontinue the medication there. From a pharmacokinetic standpoint, timolol is a substrate of CYP2D6. So that's going to be important in drug interactions, and I'll talk about that a little bit. And then with the eye drop formulation, I have seen cases where giving the eye drop has caused some systemic effects. So maybe a drop in blood pressure or a drop in pulse a little bit. Couple important things: make sure adherence, make sure they're taking it correctly, make sure they're not taking it more frequently than they should, and maybe getting a higher dose in the eye than we would anticipate. So that's one thing from a patient education standpoint, and just trying to ask the right questions and figure it out. Again, in most situations, that eye drop is likely not going to cause any systemic problems, but I think it is something to pay attention to if you've got something going on that aligns with beta blocker adverse effects, and you can't really put your finger on it if it's anything else. I think it's important to potentially rule that eye drop out if you're stuck and trying to figure out what's going on. All right, let's take a quick break from our sponsor, and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study materials like BCPS, ambulatory care, geriatrics, BCMTMS, NAPLEX, go check out meded101.com/store, STORE. We've got a great list of resources there. We've helped thousands of candidates pass their exam. Definitely go support the sponsor, meded101.com/store, which obviously helps this podcast, keep this podcast free and available for all to benefit from. In addition, if you're a nurse, PA, nurse practitioner, med student, tons of resources, tons of books, Amazon bestsellers, all sorts of different tools to help you learn pharmacology better. So please take advantage of all those links at meded101.com/store. All right, wrapping up with drug interactions. So I alluded to the fact that it is a CYP2D6 substrate. Remember, CYP is a family of enzymes that break down medications. A couple classic examples are in the psychiatric space. Bupropion is a CYP2D6 inhibitor. Paroxetine is another great example there. And so taking bupropion, taking paroxetine, or having these medications on board could potentially raise the concentrations of timolol and increase the risk for bradycardia and fatigue and some of those adverse effects that I talked about there. An additive effect type of one, kind of piggybacking on that bradycardia issue. Clonidine is a good example of a medication. That's an alpha-2 agonist that can kind of have some additive bradycardia type effects. Some of the antiarrhythmics, like amiodarone, for example, again, can kind of have some additive effects. Calcium channel blockers, specifically, kind of the non-dihydropyridines. And then, of course, I would add in any blood pressure lowering medications that can certainly have some additive effects as far as drug interactions go. I wanted to mention, pay attention to patients on insulin or taking sulfonylureas, for example. These patients are at higher risk for hypoglycemia. And recall that beta blockers, especially the non-selectives like timolol, they can mask some of those hypoglycemia signs and symptoms. So, again, something to pay attention to if your patients are reporting hypoglycemia, or maybe we're seeing some emergency department visits for hypoglycemia. Reassess if a beta blocker is contributing to the patient not being able to recognize those symptoms as well. And then last but not least on the drug interactions list, I got to mention beta-2 agonists. So that would be your LABA and SABA therapy, so long-acting beta-agonists, short-acting beta-agonists. So, your albuterols, your formoterols, they can have their action blunted by the use of non-selective beta blockers. Again, that beta-2 blockade can blunt the effects of some of those respiratory type medications. So it's going to reduce the effects, potentially put your patient more at risk for COPD, asthma type issues. So one last important drug interaction there to think about. All right, well, I think that wraps up the podcast for today. Do me a huge favor, share us, friends, colleagues, classmates, anyone who could benefit from pharmacology education. I greatly appreciate that. If you'd be so kind, leave a rating review on iTunes or whatever platform you're listening on. Greatly appreciate that as well. And of course, go find yourself some good resources at meded101.com/store. Lots of books, study materials, definitely help you prepare and pass your board exams, as well as help prepare you for clinical practice as well. If you want to track me down, Eric Christensen, mededucation101@gmail.com. Or you can find me on LinkedIn as well, Eric Christensen, PharmD, BCPS, BCGP. Don't hesitate to connect with me there. With that said, thank you so much for listening. Hope you picked up a few practice pearls today, and I hope you have a great rest of your day.